All right,
Sure.
guys. So it's 6 o'clock. Thank you all for joining us today. This is a topic very close to my heart. South Asians and heart disease. Is this a new emergent pandemic? And it kind of sounds strange coming from an interventional cardiologist who is focused more on PCIs. And many of our panelists today are interventional cardiologists. But that is something changed when I moved to Pakistan about 6 to 8 months ago, and I decided after spending 18 years in the U.S., I moved back 6 months ago and I joined NICVD, which is a public hospital. There are no financial disclosures for this webinar, except that the IT support is provided by Farmivo. We share a lot of things amongst us, among South Asians. So we represent 1/4 of humanity, and we share our love for cricket or art and music, and also for carbohydrate-rich diets like biryani and curries. But we also share this with this magazine cover on ACC Cardiology magazine. Being a South Asian. Now we are considered as high risk for coronary artery disease and heart disease. And there's South Asians typically, I mean, Dr. Birani will talk about this later, but South Asian, they develop coronary artery disease up to 10 years earlier than general population. And there's 40% higher chance of mortality from heart attack among South Asians than the average population. And there's one trend that we are seeing in terms of diabetes, hypertension, and even heart disease. It's moving more and more towards low to middle income countries, and that's where we lie here. So this is definitely a kind of pandemic, and it kind of opened my eyes when I moved back 8 months ago. I joined NICVD. It's based in Karachi, and Karachi has population about 20 to 30 million people. And this center also caters to the healthcare needs of the whole province of Sindh. It has about 10 centers or hospitals with 20-25 chest pain units. And then most of the care if you can look at the time from 1 o'clock and to 6 o'clock, in 6 hours, we got about 15 to 20 ST elevation MI. I mean, this does not happen anywhere in the world. I remember in the US, when you get 1 or 2 MIs or 3 MIs a day, it's considered a busy day. So on average, we get hit about 30 to 35 MIs. And then there's also this concept of chest pain unit. I mean, if anyone who lives in Mumbai or Dhaka, they know the traffic situation there. So not a lot of patients can promptly go to the hospital, present to the hospital. So there's this chest pain unit concept where at a lot of busy roads or intersections, there is this container which has a doctor, EKG, and defib, or if someone is coming with chest pain, they can be evaluated promptly. If they have ST elevation MI, they get heparin or Lovenox, and they are referred promptly to the main center where the primary PCIs are done. So on average, if you look at 2019 number, just in 1 year, they do about 16 to 17,000 primary PCIs, which is a huge number. That makes us one of the largest network of PCI. Nothing to be proud of, nothing to kind of thump our chest. I think it kind of prompted me more to think, why are we doing so many numbers of primary PCI? What's going on here? Even when I was living in the US, I mean, in certain cities, we used to see some South Asians, but I've never seen such a disease burden that I see here in Pakistan. And then I thought that, instead of just having speakers from Pakistan, we should invite, speakers from India and Bangladesh. Dr. Samir is here, Asha is here, and see whether they see the same disease pattern over there as well. Are South Asians living in the subcontinent are different than living in UK or US? So this was the whole idea behind doing this webinar. So I don't want to take too much time. This was the brief intro that I wanted to give. And without further ado, I'm going to invite our first speaker today. It's Dr. Saeem Virani. He's a very good friend. He's our ATU alumni. He is a professor of cardiology and cardiovascular research at Taylor College of Medicine. Is one of the authorities in the world on lipid management. So Dr. Saeem.
Sure. So, good morning, good afternoon, good evening, everyone, wherever you are in the world right now. And Sohail, thank you for setting this up, especially, and for the kind introduction. So, what I was asked to talk about is why is South Asian ancestry considered a risk enhancer for ASCVD? As Sohail mentioned, that in the last set of ACC/AHA 2018 guidelines, actually having South Asian ancestry is considered a risk enhancer where one should start therapies early on and treat them aggressively. So the job I have been given in the next 12 to 15 minutes is to talk about why is that the case. So with that, again, these are my sources of research support. So this is really what I want to talk about, the ASCVD risk in South Asians. My job is to set the platform for the other speakers, talk a little bit about ASCVD risk factor profile in South Asians, talk a little bit about risk stratification tools that we have available and why they might be inadequate. And then the question of really where does it all lead us, which is the $1 million question. We can do a lot of analyses, but really what difference are we making to the populations that we are serving here? Again, Sohail mentioned this briefly. If you look at South Asian countries, it's about 1.8 billion people. About 1/4 of the world's population lives in this very tightly compact part of the world. If you look at the Asians and South Asians in US, because I know we have quite a few folks joining from US as well, it's about 24 million based on the most recent 2020 census, about 7% of the US population. The interesting thing, though, is that there has been about 40% increase in Asians compared to 2010 and about 80% increase since 2000. So it's the fastest growing racial or ethnic group in the US between 2000 and 2020. And I have the numbers, the breakup there for various Asian ethnic groups. And you'll see that Chinese and Indians are the largest groups, followed by Filipinos and then Pakistanis and Bangladeshis and Nepalis. So you will notice that there are quite a few Asians. It's the largest growing group. Now, what do we know about South Asians when it comes to the risk of MI? What we know from Interheart, which was a very large case control study done in all the continents that are habitable right now, so 6 continents, what we know is that the median age for first MI was almost 10 years early in those who were from South Asia compared to those from China. In fact, 10 to 11% of the myocardial infarctions in this particular study, Interheart, in South Asians were in those who were below the age of 40. Now, that's an age when we don't even have any risk stratification tools available. Again, very, very high prevalence of MI, incidence of MI, as well as premature. Now, I'll show you some more data. These are data from Kaiser Permanente. And when you look at these data, what you will see is these are patients who were followed for 10 years, that the incidence of myocardial infarction was the highest in South Asians. Even when you adjust for traditional risk factors, it was twice that of white individuals. So again, it's higher incidence of MI. This is something that just got published in Circulation Quality and Outcomes, where you look at age standardized mortality rates. I want you to focus on this green line here. What you will notice is that among all the Asians, South Asians have the highest age adjusted or age standardized mortality rate, both in men as well as in women. And in fact, it looks like it's going up as well. So again, very disturbing trends. So it's not just that they have higher risk of MI. This is some of the recent data we looked at from NHIS, again, showing that when you look at any definition of premature CHD, it's much higher in South Asians compared to any other ethnic group in the US, whether you look at whites, whether you look at Chinese, you look at Filipinos or other Asians. Highest prevalence of premature coronary heart disease is seen in South Asians. That's one side of this story. The other side of this is that when you look at prevalence of diabetes, this is one of the highest prevalence of diabetes that you will see in any ethnic group, both in terms of total diabetes, but also in terms of undiagnosed diabetes. So again, I would ask you to read this paper if you have some time, where what you will see is that it's not just the total burden of diabetes, but there's a lot of undiagnosed diabetes in South Asians as well. So we talked about CHD, we talked about diabetes, but then again in diabetes as well, what you will notice is that they develop diabetes. South Asians develop diabetes at a much younger age. So it's it's not just a risk factor, but the duration of exposure to that risk factor is also high in South Asians. And we know that gestational diabetes, which is about 6% of US pregnancies, is about 17% of pregnancies in South Asia. And we know that gestational diabetes leads to long-term increase in CV risk in the mother. And now we have a lot of data that even in the offspring, it increases the risk of having cardiovascular complications in the future. We have a lot of data related to subclinical athero in the offspring of those who had gestational diabetes. So these are some of the exposures, even in utero, they're probably contributing to increased risk in the offspring as well. More recently, even when you look at hypertension, now hypertension is most prevalent in Filipinos if you look at overall prevalence in Asians. But if you look at premature hypertension, again, Asian Indians, at least living in US, have the highest prevalence of premature hypertension. This is some of the data that's under review right now. So it's not just the risk factors, but it's the prematurity of that risk factor, early development of those risk factors. That's also something that we need to consider. Let's talk a little bit about risk stratification. This is data, again, from the very large UK biobank study. And where you notice is that if you look at South Asians, the risk of having a cardiovascular event was twice that of Europeans. But when you plot out their risk scores using either pooled cohort risk equations or using Q-risk-3, there is no difference between European and South Asians, meaning that both of these risk stratification tools are underestimating the risk in South Asians, despite having twice that risk of ASCVD that is seen in Europeans. The other thing I want to emphasize here is look at these hazard ratios when you compare them to Europeans. There is heterogeneity even among South Asians. So if you look at Indians versus Pakistanis versus Bangladeshis, you'll notice that Pakistanis and Bangladeshis seem to have higher risk of ASCVD. So we are just at the tip of this iceberg. Even among South Asians, there is a lot of heterogeneity, and I'll come back to this point again. So that is why when we look at any risk stratification algorithm, it works well at a population level, but at an individual patient level, it may not work very well. In some, it may overestimate risk. In some, it may underestimate risk. And South Asian ethnicity, as I just showed you on the last slide, is a group where it actually underestimates the risk. And that is why then in 2018 guidelines, we came up with South Asian ethnicity as a risk enhancer where clinicians could start therapy early on. Now, these are data from Dr. Grundy and colleagues from early 2000s showing that even when you look at similar body fat composition, insulin resistance is higher in Asian Indians, and similarly markers of inflammation, in this case hsCRP, are higher. So it's not just diabetes, even resistance as well as inflammation very early on is higher. When we talk about lipids, what you will notice is that LDL cholesterol is not any higher in South Asians compared to other groups, although HDL cholesterol levels are lower and triglycerides are higher. But the other important thing is that we should not be fooled by relatively normal LDL cholesterol levels in South Asians. What you will notice here is that for the same LDL cholesterol, South Asians have a much higher ApoB compared to all other ethnic groups. What that means is that for the same LDL cholesterol, South Asians have a larger particle count. And you know, the way I use this analogy is what causes a traffic jam on the freeway? Is it the number of cars on the freeway, or is it the number of people sitting in each car? Well, it's the number of cars on the freeway. And that's what LDL particles are. So for the same LDL cholesterol, South Asians have much larger particle count compared to most other ethnic groups. And that's why the risk might be higher. Here, there are these 3 studies I have listed. HDL cholesterol levels are lower, but even HDL cholesterol levels, when you adjust for the levels, it would seem to be that dysfunctional HDL cholesterol, the prevalence of that may be higher in South Asians compared to other ethnic groups. There's one study showing that even carotid IMT is associated with dysfunctional HDL cholesterol in South Asians, and HDL cholesterol may not be as protective in South Asians. probably because of higher inflammatory milieu that's present in South Asians. Lp(a), we all know, is an emerging risk marker. We now have therapies that are under development. We know South Asians have high levels of Lp(a). And what we have seen in UK Biobank, that African Americans have the highest levels, followed by South Asians, then whites, and then Chinese. And we know that there is a monotonic association with ASCVD as well. So a lot of these risk factors are much, much more prevalent in South Asians. We know subclinical atherosclerosis is, Dr. Khurram Nasser is going to talk about it, but even when we look at angiographic CAD, this is one study from UPenn comparing South Asians to Caucasians, showing that actually in South Asians, we have much more higher prevalence of multi-vessel CAD. And in fact, luminal diameter was also small in this, making interventions that much more difficult in South Asians. So again, I've talked about some of these risk factors. They start in utero. There's genetics, there's air pollution, there's diet, there's thrifty gene hypothesis. There's a lot of stuff that we know, but there's a lot of stuff that we don't know. Last but not the least, if you look at all of these ethnicities, they are all different, even among South Asians. This is data from US. If you look at Indians versus Pakistanis versus Bangladeshis, you look at income, you look at education, there is a lot of difference. And that is something we need to explore now. And this is a study done by our good friend, Miguel, showing that even amongst these groups, these are data from Spain, showing that the risk of various cardiovascular phenotypes is very different when you look at Pakistanis versus Bangladeshis versus Indians. So even among South Asians, there's a lot that we need to learn across these various ethnic groups. But wait, there is hope. I have given you a lot of negative stuff here. But again, if you look at Interheart, there were 9 reversible risk factors that could explain 90% of premature MI. And then in South Asians, when you adjust for these reversible factors, the risk of having an early MI becomes equal between South Asians and other ethnic groups. So again, current risk stratification algorithms tend to underestimate risk of ASCVD in South Asians. We have a distinct bioprofile related to measures of insulin resistance, biomarkers, and lipid markers. Diabetes and CHD is more frequent and more premature in South Asians. Premature hypertension also appears to be more prevalent in South Asians. There is an ongoing need for further disaggregation of ASCVD risk among various subgroups of South Asian individuals. So I hope that with webinars like today, South Asian ethnicity, which is considered a risk enhancer, hopefully it will lead to some work in South Asians that will make it a risk equal in the next few years to come. So thank you for your time, and we'll take some questions either now or later. We'll pass it on to Sohail.
Thank you, Salim. It was a great talk. So what I was thinking that we should keep questions till the end because we will have plenty of time. But just to kind of take home messages that I got from you, and this has been my experience too, or many others who work at NICVD, and a lot of younger patients who come with MI, their LDL is, I would say more than 90% of them are normal. So that is something that we do not check for lipoprotein A, and that is something that we should definitely look into. And the second thing that we see consistently is we don't talk about the social determinants of health, which is poverty, and maybe that is one of the reasons too for this high incidence of MIs here. And that is something very close to Khurram's heart, and he is into healthcare policy making, so we'll definitely talk about it later. Our second speaker is Dr. Aisha Kadir. She's from Bangladesh, Dhaka, Bangladesh. She's assistant professor at Department of Cardiology, Ibrahim Cardiac Hospital and Research Institute. And she will talk about CVD disease, current landscape in Bangladesh.
Thank you very much, Sohail. Thank you for organizing this and also for asking me to speak. So I've been tasked with speaking on cardiovascular diseases in Bangladesh with a description of the current landscape. I have no disclosures relevant to this talk except that I'm an interventional cardiologist. We do a lot of coronary work, and that will comprise the bulk of the data that I show as well, because that's really the bulk of the data that we have available. Very briefly, for those that may not know, Bangladesh is a country in the Bay of Bengal. I'm not originally from here. I've lived here for over a decade, but I'm originally from way south at the bottom from Sri Lanka. Anyways, Bangladesh has an area of about 65,977 square miles and a population of just over 160 million, a vast majority that's concentrated in cities, and a life expectancy of about 72.5 years. So our elderly patients are not really elderly as compared with what the global north might consider. So in terms of epidemiological transition of disease, in the 80s, of course, communicable diseases was the predominant cause of mortality in the country. But over the last 2 to 3 decades, we've seen non-communicable diseases take over in terms of mortality. And when we look at data from the WHO non-communicable diseases profile, cardiovascular diseases comprises the vast majority of these NCDs. And also when you look at risk, once again, from this WHO NCD profile, you will see that the dark lines are the past trends, the lighter lines are projected trends, and the dotted lines are where global targets are. And when you look at projections as well as data for the country, tobacco smoking is, and the blue ones are for men, the red is for women. The tobacco smoking is still about 10 percentage points shy of the estimated global targets. Obesity did not used to be a problem, but it seems to be an emerging risk factor, and particularly perhaps metabolic syndrome. And we can see that hypertension has remained static, but is still shy of the global targets that should be achieved. So in terms of risk, again, this was a study that was published about 4 years ago on metabolic syndrome, where the weighted pooled prevalence of metabolic syndrome irrespective of gender was about 30% in the population, higher in women, and highest when modified NCP83 criteria was used to define it. Also, when 10-year risk, when this nationally representative survey of 10-year risk of CVD among the population was seen, 1 in every 4 Bangladeshi adults had elevated CVD risk, and men were shown to have higher risk than women. So if we look at the CVD landscape, I've got CAD there as the big red pentagon, because that's really the predominant killer, the one that also kills younger patients. And rheumatic fever and rheumatic heart disease used to be a problem, but has gradually been curtailed, as I will show with some data. And among the others, we don't really have a lot of population-based data on heart failure, arrhythmias, and congenital heart disease. So there's also some work to be done. So as I said, in terms of prevalence, hypertension, it's around about 15 to 24%. Coronary artery disease in the population is about 4 to 6%. And we have a reducing prevalence of rheumatic heart disease. This is chronological data from the 1970s. So I'd like to show some acute coronary syndrome data, and this is the largest registry of ACS that was published and came out of our center. We looked at 1,914 patients. This data of about 3 or 4 years back. We currently have a more contemporary analysis being undertaken. And when we looked at predictors of mortality, was about 7.6% overall. Needless to say, greater in STEMI than non-STEMI and unstable angina. About 10.5% among all of the mortality was in STEMI. And when we looked at risk factors, clearly those that had mortality had greater diabetes, as well as CKD and a history of prior stroke. Also, those who had in-hospital mortality was significantly less likely to undergo an angiography, PCI in the index admission, as well as primary PCI. And when we looked at the predictors, an age greater than 50 years, as I said, 70 is elderly in the country. CKD, shock, left ventricular failure, and a presentation of STEMI were independent predictors of mortality with greater odds. And when we compared this data of 7.6% with contemporary registries from the region as well as the global north, we found that it was relatively comparable with that of the CREATE registry, of course, very shy of Kerala registry, which had very low mortality rates, and also comparable with Malaysian NCVD data. We also undertook a sex differences analysis. So there was a male-female ratio of about 2.5:1. consistent with global data, women in our population were also, who presented with ACS, were also older, with a mean age of about 59 compared to about 57 among men. They had better ejection fraction. And when you look at the risk factors, you'll see that there's a clustering of risk factors that is higher in the pink bars, representative of women, particularly diabetes, hypertension, and CKD. Of course, my hospital is an enterprise of the Diabetic Association of Bangladesh, so about 60 to 70% of our cases have diabetes. And as Dr. Virani said, that is a lethal and emerging risk factor as well. As for sex differences in the distribution, women presented predominantly more with non-STMI and unstable angina. Men had a greater presentation of STEMI. And as you can see in the first bar there was a higher incidence of MINOCA among women of about 30.8% compared to just about 10% among men when we looked at angiography. And once again, consistent with findings internationally, women were less likely to undergo, significantly less likely to undergo coronary angiography, significantly less likely to have PCI in the same admission as well as primary PCI. And we didn't look at the determinants of this, but this is data that prompts further research. However, despite this, we did not find that there was greater mortality among women. There were no differences in terms of mortality. And in fact, the only significant difference in hospital event rates was a significantly higher acute kidney injury that we saw in men as compared with women. What about young MI? This is data coming from the National Heart Foundation of Bangladesh by Professor Malik and colleagues, where they looked at, this was not a comparative analysis, they only looked at observational data of about just over 250 young patients defined as less than 35 years who presented with their first diagnosis of MI. And just over two-thirds of them were between the ages of 31 and 35. That's something we see very frequently in recent times, and over 94% of them were men. That is also something that anecdotally we see at our center as well. In terms of risk factors, 3/4 of these young patients are smokers, and very often anecdotally also present with ectatic coronaries. And as you can see, the other traditional risk factors like hypertension and diabetes are less prevalent, but a family history of ischemic heart disease is greater among young patients with MI. Also, some other novel risk factors, about greater than 50% had hyperhomocystinemia, and a sedentary lifestyle has also been seen as a risk factor, as is excess fatty food consumption, as reported by the patients. In terms of outcomes, however, there was lesser mortality among these young patients. The reasons have not been analyzed. Maybe less aggressive presentation or earlier presentation to the hospital could be factors governing that. As for sex differences in young MI patients, this is an analysis that we undertook. And here again, we found that even among young patients, here the cutoff was actually 45. And we found that women were older. And although we didn't have any cigarette smokers among the women who presented, smokeless tobacco, which is quite common in the region, was seen to be greater among women than men, as was the clustering of traditional risk factors of hypertension, diabetes, and dyslipidemia, as well as a family history. And again, this is the distribution of STEMI presentation. Once again, STEMI was the predominant presentation in these young patients. And when we looked at the outcomes, although there were no periprocedural or differences in terms of mortality in this young population, we found that vascular access complications and bleeding were predominantly greater among women, as was repeat hospitalization at 30 days, which was mainly driven by recurrent ischemia rather than a target vesicle revascularization at 30 days, and therefore resulting in greater net adverse clinical events, again, predominantly driven by bleeding rather than MACE. And female sex was an independent predictor of adverse short-term outcomes in this population. Some interesting data, which is collaborative and very large research in collaboration with the University of Cambridge, is the BRAVE study, which is an epidemiological bioresource established study, which examines a lot of factors: environmental, genetic, lifestyle, and biochemical determinants of CAD. Because we have the data, we need to find the risk factors that propagate this this pandemic of CAD in the country. And so they enrolled 5,000 confirmed first ever MI cases at 2 centers in the capital city of Dhaka, with another 5,000 controls that were frequency matched by age and sex. And in the initial 3,000 cases and controls, they also did genotyping using, I'm literally just going to read this off because these are not assays that I'm familiar with, cardio-metabochip and the exome assays. And interestingly, and this is also something that would add to what Dr. Virani spoke of, initial analysis from this study indicate that Bangladeshis are genetically distinct from major non-South Asian ethnicities, as well as distinct from other South Asian ethnicities, which really begs the question if we should even be grouping the entire ethnicity altogether in terms of risk. And these are other biologic measurements that they have planned or in progress, which should yield some interesting results. As for how about the PCI capable centers in the country? Although we have about 70 labs in 44 centers dispersed, the vast majority of them are concentrated in the city. So a lot of patients are seen transporting themselves to the capital city for PCI, and we see also a lot of pharmacoinvasive therapy. As for why there is a less uptake of and delays in STEMI care in the country, because we haven't had as enough primary PCI as one might like. One of them is, of course, a lack of awareness of the symptoms, a delayed presentation, and one of the bigger problems is overcoming traffic and transport and the fact that these patients live very far away from the nearest hospital. Dr. Khan spoke of socioeconomic determinants of health, and we don't really have data for it, but a surrogate is perhaps, again, this data coming from one of my mentees, where we looked at pre-hospital delay, and one of the significant factors that associated pre-hospital delay is not just atypical chest pain and diabetes, but also living far away from the nearest hospital and lower and middle socioeconomic strata. So in conclusion, what are the challenges and the future? The CAD pandemic is massive, particularly young MI, as we've seen time and again. Socioeconomic determinants of health play a role, but are understudied. We also lack data on risk factors, novel risk factors, genetics, phenotyping, and therefore the focus really needs to be multi-pronged. We need to improve our existing services, particularly for revascularization, decentralize cath labs, and have a more focused focus on prevention and research in those aspects. With that, I'd like to thank you for the opportunity. This is my center and the members of our cath lab, and I'm happy to take any questions. Thank you.
Thank you, Aisha. It was a great talk. It is indeed a pandemic, no different than what we see here in Pakistan. The one thing that I would make a comment is that one of that study by Dr. Malik in younger patients, 94% were men. Do you think the reason is just like we see gender disparity and in Pakistan, and I'm sure that's going to be issued there, is it the heart disease or MI is underdiagnosed or misdiagnosed, and it could be that the reason for that is the gender disparity that we see? Because 94% only men is too good to be true. You just cannot have all that, not women in it.
I would agree. I think it's also maybe they're just not presenting. That's really probably it.
Perfect. So next speaker is Dr. Samir Gupta. He is Group Cardiac Cath Lab Director at Metro Group of Hospital, New Delhi. And he was in the same boat a couple of years ago that I'm in now. He also trained in the US and recently, a couple of years ago, returned back to India. And we're just curious how his experience been so far. Samir.
Thank you, Sohail. Thank you for putting this entire thing together. I would kind of echo your sentiments as to, when you come back and you start seeing a lot of heart disease, your first question is, am I missing something? Is it just the population? And then you delve into a little bit more and you try and figure out that there is something else, there's something that we really don't know and something that we're missing. And over the next few minutes, I'll talk about the heart disease epidemic in India, what I am seeing, what the data shows, and the path forward. So I don't have any disclosures relevant for this talk. And like most presentations, I'll start off with the case. This is just a usual case that Aisha can attest to, that Sohail can attest to. Somebody, a 37-year-old person, male, comes to the hospital with chest pain, says this for 3 to 4 hours. He has not had any history of similar pain in the past. His risk factors: he does not smoke, no diabetes, no real family history. Blood pressure says, I got it checked a couple of months back. It was high. I just took some local medicines and, I'm not on any good treatment. His cholesterol, his total cholesterol is 224. His LDL cholesterol is 140. His HDL is, it's 140. It's not that high for that we would start treatment. And his HDL cholesterol is 34 and his triglycerides is 243. This is a classic patient we would see in our hospital. And you can see over here, his right coronary artery is completely occluded. He has severe disease in the circ. And he has an ostial LAD lesion. So he has triple vessel disease at the age of 38. This is a normal day in the cath lab for us. This is absolutely normal. We see this every day. And every time we see it, we ask ourselves, why is there a coronary artery disease pandemic? So like Aisha had also said, I'll just talk a little bit about India, a little bit about the demographics. It is a country of 1.4 billion people. There are 28 states and 8 union territories. There is a literacy rate of 74%. Literacy by definition means you can read and write your name, you can read a sentence, not necessarily read a complete book. 82% of the men in India are literate and 65% of the women. There are about 8.15% are college graduates and 39% of India consider themselves vegetarian. This is important because I will talk about this later. About 65% of India lives in rural areas, which is down from 72% in 2000. So in 20 years, there has been a demographic shift of people moving to urban areas. This has also led to a higher per capita income. Our per capita income now is almost $2,000 compared to $443, which was, so it's almost increased 4 to 5 times in a span of 20 years. The average life expectancy is also increased. It's now 70 years compared to 78 in the US, 67 in Bangladesh, and 67 in Pakistan and 72 in Bangladesh. And if you look at this 25 to 27% of all deaths in India are because of cardiovascular diseases. Like Dr. Vermani had said earlier, that Indians do get coronary artery disease almost 10 years earlier than our Western counterparts. And in the Western population, 23% of cardiovascular deaths occurred before the age of 70 years. In India, this number is 52%. And when you look at MI, 25% of MIs are in patients who are less than 40 years, and 50% of CAD deaths happen before 50 years of age. And the Pure study has also shown us that Indians and Southeast Asians have more severe disease and poorer outcomes. When you look at the burden of disease in India, this is data from multiple registries and multiple studies that has been pulled together. When you see the proportional of cardiovascular deaths, that number is somewhere around 25 to 26%. But when you start seeing the 8 standardized risks, you will see that the Indian numbers are much higher. India in general has a much higher 8 standardized cardiovascular mortality compared to the US or to the globe. And when you look at more affluent states like Mumbai, and when you look at more affluent places like Mumbai or Kerala, that number is certainly even higher than the national average. When you look at the burden of cardiovascular disease, this is the 8 standardized death and disability rates. The death per 100,000 ischemic heart disease is 144 compared to the global average of 104. The same thing holds for coronary vascular, for CVAs, for cerebrovascular disease, rheumatic disease, hypertensive disease, cardiomyopathies. Atrial fibrillation, the data is not very strong, but that is comparatively lower. Once again, it could be because of lower diagnosis, not necessarily lower incidence. Aortic, the same thing goes for aortic aneurysms and other miscellaneous diseases. But overall, if you see a comprehensive overview, the cardiovascular death and disability per 1,000 is much higher in India compared to the global numbers. This has also been replicated in multiple registries. In the Kerala ACS registry, less than 50% of STEMIs and less than 30% of NSTEMIs underwent reperfusion. This number is now changing with more advent of cath labs and more insurances coming into the picture. But this is data from the Kerala ACS registry. And the CREATE registry showed that in about 21,000 people, a higher proportion of STEMIs were there in India compared to the rest of the world. In the Clarify registry taught us that patients in India were younger than the rest of the world and had a higher prevalence of diabetes. And the Indian Heart Rhythm Society showed us that the mean onset for atrial fibrillation was also 10 years earlier than the Western counterparts. So it was not just CAD, but also atrial fibrillation is more happens earlier than the other parts of the world. When you look at risk prevalence, there are about 8.7% of people in India are diabetics compared to 10.7% in the US. When you delve down into this a little bit further, you will realize that there is a higher, in terms of sheer number, because of the population of India, the actual number of diabetics is huge. And also India, as Dr. Virmani had said, because of the phenotype of Indians and the Southeast Asians, there is a higher incidence of insulin resistance. India has about 30 to 35% hypertensive. This is by the old definition. The definition changed after the sprint, and this number will probably also increase for hypertension as it did in the US, where almost 47% are now hypertensive. Tobacco use is very rampant, whether it is in smoking or in smokeless tobacco. 30% of India uses some form of tobacco. This is more so in the lower socioeconomic groups, but is also there in more urban areas. And as far as hyperlipidemia is concerned, this is all data from Indian registries. 25 to 30% of people in urban areas have some sort of hyperlipidemia compared to 15 to 20% in the rural areas. And when you look at this, 79% have some sort of lipid abnormality done on the lipid profiles. So what is the most common cause of death? Ischemic heart disease is certainly the number one cause of death. And this number has increased by 40% in the last 10 years. Even stroke, the incidence of stroke has gone up dramatically by 30%, and so has diabetes. Diabetes incidence has increased by 55% in 10 years. This is data from the Global Burden of Diseases published in Lancet in 2016. Because of better the government focus and a lot of not-for-profits working very hard, the death from diarrheal diseases and neonatal disorders has gone down dramatically. What are the risk factors which are driving these death and disability? You can see malnutrition and air pollution has gone down, but hypertension, tobacco, high fasting plasma glucose, dietary risks, high body mass index are all increasing in the last 10 years. When you look at hyperlipidemia, this is data from a large hospital database, and you can see that that 79% of adults in India have some sort of cholesterol abnormality. Low HDL is one of the most common things, almost 72%. Increased triglycerides present in 30%, and high LDL, like one of the previous panelists had also commented, it's not very high when you see them with ACS, but a high LDL is 11.8%. So decreased HDL plus high triglycerides leads to atherogenic dyslipidemia, which is very commonly seen in this. This is data from the NIC. NIC CSI is the Cardiology Society of India, and they have a national interventional council. This is data from their presentation last year about the coronary intervention data for 2019. So approximately so not all hospitals participate in the registry, so you have to take this with a pinch of salt, but it kind of gives you an overlay of the land. So there were approximately 330,000 MIs in 2019, out of which 50% got thrombolysis and only 2.3% got primary PCI. When you look at the data for primary PCI, the number has slowly and steadily been increasing. There are almost 500,000 PCIs which are happening in 2019, leading to a CAGR of about 12.6%. When you look at data by age group, the numbers are also increasing every year. This was data in 2017, 2018, and 2019. And you can see that these numbers are slowly and steadily going up also. This is by gender, like the previous speaker had said, about 70% of all PCIs happen in men and 30% are in women. And when you talk about insurances, most of the people who are paying are are from some sort of government insurance, is about 55%. But you can see over here that own pay, self-pay, or people who are paying out of pocket, that number has gone down significantly over the last 3 years, from 40% down to 30%. These are some of the indications for PCI. Primary PCI was about 18% of the entire pie, and post-MI angina, which could be facilitated PCI, or if somebody is unstable after PCI, this could be the post-MI. And then you have rescue PCI and cardiogenic shock. So almost 60% of people had an intervention somewhere related to the STEMI or an ACS presentation. In acute MI, the numbers of interventions for acute MI have gone up. This is once again because of more awareness, more opening of labs, better accessibility, better availability, and more affordability. The 4 A's in healthcare has led to better interventions in acute MI to almost 15%. This is the amount of stents that were used. There were almost 6.5 lakhs, almost 600,000 stents which were used. This number is also going up every year, which kind of, is in tandem with the number of PCI cases that are happening. Now, some other statistics in terms of cardiologists, there are about 5,500 cardiologists. They are members of CSI. This is, and compared to the US, which has almost 22,000 cardiologists. The unofficial industry numbers are more than 6,000 to 7,000 cardiologists, because not everybody is a member of the organization. The official number is about 900 cath labs in the country of 1.4 billion, but unofficial industry numbers say it's more in the range of 1,500 to 2,000. As far as stent usage is concerned, that's about 50-50. There are MNC players, which are the FDA approved players, and then there are the other indigenous stent manufacturers in India. That number has gone up dramatically over the last few years. I'll talk a little bit about our hospital and what we see. We are a group of about 10 hospitals in North India. Our annual PCI volume is about close to 6,000 PCIs, and our flagship hospital, where I head the lab, is about 2,500 PCIs a year. We recently started a registry. We've made some attempts to start a registry and try and understand some of the patient demographics and our outcomes. So this is a first cut of what you're seeing. Hopefully by the end of the year, this registry would have gone to more hospitals, and we will get some more granular level data of risk factor profiles and treatments. So if you can see over here, majority of our patients were 60 to 69. This is 500 PCIs, close to 500 PCIs that we did in the hospital in a span of about 3 months. About majority of our patients were 60 to 69, but there was a significant percentage of patients, more than 10%, who were in the 20 to 40 age group. After that, and as you obviously age, the number of procedures went up in them. This is the just one second. The indication was STEMI for about 167 patients, which is 167 out of 500. Almost 30% of patients had STEMI as a diagnosis. Out of which out of which 5, there were 51 times we did primary PCI. For the rest, it was delayed, facilitated, and they were not counted in this 51. But for these 51 patients, RCA was the most common culprit artery, and after that followed by LAD and OM. I think there is some bias over here, because patients who the RCA patient may have driven the extra distance to get his care, compared to an LAD patient who was probably got his first cut at the local hospital. This is the risk factor profile for some of our patients. We had about 41% of all our patients were diabetics. There were 54% who had hypertension, and almost 30% had some sort of family history in the risk factor profile. Now, I know that significant family history is 55 and 65, but this is more for any family history that was noted, in a first degree relative was noted, and the granular level details we will come to know as we analyze the data further. Now, what about dietary patterns? I said that almost 40% of India consider themselves vegetarian. Well, if you look at the National Family Health Survey, which was a self-reported survey of almost 150,000 patients, 150,000 individuals, 50% of them said they consume 0 or 1 serving of fruit in a week. And there was a social gradient in the consumption of fruit. The lower socioeconomic group had the lowest consumption. Also, when we cook food in India, there's a lot of overcooking which happens, which leads to a lot of loss of micronutrients and other antioxidants. And then between 1972 to 2000, this is the National Sample Survey Organization, what they found was that even though the net calorie intake had not changed that much, there was an increase in the intake of fat from 36 grams to 50 grams in individuals. There is also poor physical activity in India, and we can talk about that at a later date. But another very important thing we don't talk about enough is air pollution. Air pollution is very prevalent in most parts of India. I live in Delhi. It is the capital, and it has extremely toxic air levels at most points. The air quality index, which in other parts of the world may be 50, 60, in Delhi, it often runs to, more often than not, it runs to about 300, 400 with very high PM 2.5 particles. And air pollution is right over here, right next to cigarette smoking, is a very important thing, which I feel is contributing to the cause of the CAD pandemic in India. This is a lipid profile test of a patient. This is pretty interesting. As you can see, she's 11 years old. I treat her father for pulmonary hypertension. He has really bad COPD. So we run a pulmonary hypertension clinic. So her father came with me. Her father came for the appointment, and he just showed me a cholesterol report. He said, "This is my daughter's cholesterol." The daughter was sitting right there. She was 11 years, maybe a little bit on the heavier side, but not, I wouldn't call her obese. But she was a little bit heavy. And he said, "I got this thing done. What are your thoughts? Should she be on medicine?" And as you can see, this is just a month, 2 months ago. And her total cholesterol was 200. Her LDL cholesterol was 120. And her non-HDL cholesterol was 143. It left me speechless. And I asked him, I said, this person is morbidly obese. Does she eat chocolates? Does she eat pastries? Does she eat cookies? He's like, yes, she does that often. I said, have you ever thought of putting her on a diet? Her cholesterol is high. And his answer was, if she doesn't eat now, when will she eat? So this is kind of just this thought really struck with me as to the mentality of the people towards food and the ignorance towards healthcare, even though there's somebody in their house who might be suffering from an illness. Suhail asked me to talk about some policies. So the government has started the National Health Mission. This was the National Program for Prevention and Control of Cancer, Diabetes, and Cardiovascular Disease and Stroke. And this was started in 2010. And this kind of clubs all the non-communicable diseases in that. And via this mission, they are trying to improve the awareness and primary treatment for heart disease and non-communicable diseases. And I saw there's a 2015 update that they've diagnosed 90,000 people who have cardiovascular diseases. And they've diagnosed 8% of the people who've come up there were diagnosed with diabetes and 12% with hypertension. The way healthcare works in India is a little bit different than the way it works in other parts of the world, especially the US, in the Western world. Over here, we have a very robust private setups, and blood tests can easily be done at home. And most people, especially in urban areas, not necessarily in rural areas, they avail of one of these packages. It is expensive, but not prohibitively expensive. And they get themselves tested at home, and then they usually send these reports to their treating doctor or to the family doctor for a first look. There are also a lot of screening camps that happen at offices that tie-ups with corporates, with the Residents' Welfare Association. There are multiple health checkup camps that are done in most cities around the country, where they try and screen patients for hypertension, diabetes. They can have something for liver disease. They can have cancer screening camps, etc. Regular health checkups are also done, and they're sponsored by the employers for their employees in most corporates and in some private organizations also. And most hospitals, most private hospitals around the country have health checkups where you can go and get an echo, ECG, and a treadmill test after a quick consultation with a physician. Most healthcare facilities, big healthcare facilities, are also doing a lot of outreach in tier 2, tier 3 cities to get specialized healthcare that may not be available in those cities to those patients who are living in these cities. And after COVID, digital healthcare has certainly has accelerated the shift and really changed a lot in terms of accessibility of healthcare. Now, there's been a complete, there are a lot of private apps, and using these apps, people in tier 2 and tier 3 cities can easily get a consultation with a cardiologist, oncologist, or any specialist in sitting in a metro city. The way forward in India is India has done a very ambitious project of the PNJ scheme, which is going to provide healthcare, which is in the process of providing healthcare to most low socioeconomic status patients. And and a lot of big corporates and private hospitals are also now getting empaneled. So if anybody needs healthcare, if anybody needs basic PCI, for example, they can go to a PCI empaneled hospital in their area and get the required treatment, and the bill is going to be given by the government. So this is a very ambitious scheme. We are working very hard to make it successful, and we hope that this will really change the scope of healthcare in India. So, whenever we look at healthcare, when you look at healthcare across the world, or especially if I have to say about India, there are the 4 A's, right? The first is availability. Is this available or not? Whether that's in your country, whether that's in your county, wherever that is. And then comes the question of accessibility of healthcare. And the same thing goes, and all these things can be easily extrapolated to coronary artery disease or for heart disease for that matter. Then comes the question of affordability. And then in the end, you start talking about accountability or quality. So we are probably somewhere in the range of accessibility and affordability. And after these things are a little bit set, I think there'll be a big emphasis on accountability and quality by creating national registries for PCI and other diseases. I think there's a big interplay of social and biological factors in India that increase the incidence of heart disease in India, but also in Southeast Asia in general. More research is needed to better understand the biological factors. I know Dr. Vermani had said we know a lot, but there's a lot more we don't know. And I think there's a lot more we don't know. And I think this will be very important as we go forward, because primary prevention remains the key. And the various schemes and policies are being developed to improve all the A's of cardiovascular care in India. Thank you so much.
All right, thank you so much, Samir. We have 2 more talks, so it's good to get an Indian perspective as well. It was a thorough review of that. My next speaker is Dr. Khurram Nasir. He is the professor of cardiology and head of preventive cardiology at Houston Methodist. And now we know the disease burden in South Asia, so he will share what can be done in terms of are there any traditional or other tools for CVD risk stratification and management decisions. Khurram.
Hey, Sohail, first of all, congratulations, and what a wonderful session. And I truly learned a lot. And, I'm not going to speak a little more around the South Asian and the risk factors. What I was thinking about, can we incorporate a newer concept? Can we dare to be a little brave? Are we ready to shift emphasis from risk factor to disease detection? Maybe not yet, but I think so. We're at the cusp of something important. So moving ahead, I'm so delighted that the work of many folks out on the panel, as well as others all across the country, all across the globe, has now finally given us the insight that yes, as an ethnicity, South Asians are truly at high risk, and kudos to Salim and their working group and the guidelines, making it as a point that now we can treat them more aggressively. The question that I have is that enough? Because maybe the most asked question within cardiology, and rightly so, especially more applicable in 2022, is what is your risk? And it has implications. One is, of course, the decision becomes, apart from aggressive lifestyle, whether to commit to a pharmacotherapy for lifelong. And not only that, the intensity of that. And now in the emerging world where we are seeing exponential growth beyond just low dose statin and conversation around aspirin and newer cardiometabolic therapies, which I believe are going to have tons of application in the South Asian population, it becomes a critical issue around resource allocation. So, but of course, if you look at traditionally, even in the current era where the focus is moving more towards law of average to precision medicine, we're still focused on risk factor approaches, which I think so worked very well for us over the last 3 decades, but it all depends which age and which group you're talking about. With Sohail, you pointed out that a lot of people, especially coming with MI in the South Asian younger patients, tend to have normal lipids or may have lower risk factors. And, you know, that's not only limited to South Asia, even in US, especially among the younger individuals presenting with their first MI. In the past, if you would have looked at the majority of them would be considered low risk with only about 10 to 15% high risk. Whereas now if you kind of widen the statin club or increasing the individuals who can get on statin, especially with age, you can clearly see that we are overestimating almost 50% or more among actual events that are happening versus predicted. So it's kind of a big dilemma that the individuals, as a preventive cardiologist, where most of the patients who are coming into my clinic and I'm looking at them in their mid 40s, early 50s, even early 60s and saying, what are you, who are you? Are you at risk? How aggressive do I need to go in? And truly, I can tell you that the risk factor approach in practical terms is as good as a coin toss. So the question really is, are we ready to stop making wild guesses and making more educated ones? And thankfully, I see Dr. Narola, my guru out here, who really taught us that why not focus where the money is? And it's all about, if we believe that, especially from CHD standpoint, if corneal atherosclerosis is the most important, I would say not surrogate, but actually the disease that causes the complication, why not focus on that? And I'm going to speak a little bit about the coronary artery calcium for various reasons. One is we have the most literature in this space. And this is one of the easiest tools that available that doesn't require any contrast. It's inexpensive, by the way. In Pakistan, when I was in Lahore a few months back, it's been done all across the country, somewhere in the range of 2,500 to 3,000 rupees. It's widely accessible. It takes 3 to 5 minutes, and radiation is really not an issue. And by detection of calcification, you can identify those with the earliest atherosclerotic plaque. And why I'm very excited about the calcium testing is, again, clearly over the last decade and a half now, it's almost established without a fact that this is if the highest burden of atherosclerosis is the most strongest predictor of heart disease all across the age groups, maybe the only risk factors that truly discriminate among those who are going to have an event or not. And we keep on talking about BNPs and the LP little a's. Yeah, they do have value, but very limited. But critically important, as a physician, as a health system with limited resources, it allows you to reclassify groups, especially where you're uncertain, almost 1 and 2, where you can upgrade treatment and low grade treatment. So not only identifying the right patient at the right time, treating them with the right treatment, but also appropriate resource allocation at the health system level. Or more importantly, also, not only it's among the tests that identifies those who have the highest risk, maybe a very unique feature of this test is ability to rule out those who don't have atherosclerosis, and more importantly, at a very low risk of having an event where management can be very flexible. And again, recalling back, this concept was brought up almost 12 years back and none of the journals were accepting it, except for the forward-looking Dr. Narola, who had the courage to get them in and now cited more than 1,000 times. So Dr. Narola, thank you again for all the support way back then. But the reason why I'm more excited about the calcium scores and atherosclerosis in 2022, or even almost a decade back, is clearly you can see huge discrimination or disparities around atherosclerosis and risk factors. So you may have multiple risk factors, still almost about 1/3 will have no plaque, whereas among people, you and I going to be reassured that they're doing well, almost 22% will have some burden of atherosclerosis, with almost 1 in 10 or 1 at 12% with significant atherosclerosis. And what about dyslipidemia? We've been all be talking about dyslipidemia, but you may not have any any lipid abnormality, and still about 42% will have atherosclerosis, 1 in 5, with tremendous amount of calcium greater than 100, where we may be significantly concerned about those with all their lipid panels being abnormal, but 1 in 2 would have no atherosclerosis. But really, why do we care? We really care about outcomes. And when you put together the risk factors or the lipids, clearly you can see it doesn't matter how you slice or dice the pie. It is your atherosclerotic burden that carries the highest weight. For example, if you have a calcium more than 100, it truly pushes you in that CVD risk equivalent, but you can have multiple lipid abnormalities, even Framingham risk up to 20%. And if you have no calcium scores, your 10-year risk, which will also predict, hopefully, the next 20 to 30 years, it's pretty low, whereas just the minimal amount of plaque pushes you even at a higher risk as somebody who has multiple risk factors. Not only that, it's not only about risk factor dyslipidemia. As I said, you can slice or dice the pie by inflammation. I know we spoke about the polypill candidates. Even 50% of the polypill candidates have no atherosclerosis. The question is, are we ready to distribute scarce national resources to individuals who are unlikely to benefit? So in US, and I think so, of course, the same thing can potentially apply in the South Asian population. Not only everyone is a high risk, because almost 1 in 2 individuals who would be candidate for a statin, at least a long-term commitment within the short period of time, they have a calcium score of 0, and truly their risk is below the threshold for considering statin. So, in 2022, at least in US, and depending upon which population you're talking about, the main role is around shared decision-making and as a decision aid, because honestly, treat all may not be the best policy, and more importantly, committing the patients as well as committing the scarce national resources towards treatment may not be the best option. And there is definitely value of treating the right patient at the right time. If you look at this paper across the entire spectrum of the pre-test risk, looking at almost all the options that we may avail in our clinic, truly it's the absence of the calcium score that can de-risk and allow for more flexible choices. Even introducing the calcium testing upfront for even generic statin seems to be a cost effective. And for many who continue to harbor fantasies that treating a lot of individuals, if you don't have atherosclerosis, can make a meaningful differences, Todd Villanes clearly showed that over a 12 period follow-up, individuals with the calcium score of 0, you can treat them as much as you want with statins, likely very minimal benefit. It's only seen if you have atherosclerosis. Makes sense because you need disease to reduce risk. And for calcium greater than 100, all you need to treat is 11 individuals to prevent 1 event. Also, at the same time, South Asians are going to have a higher risk for diabetes, metabolic syndrome. I truly understand that we need to push the envelope a little bit more, may include a low dose statin. But the question is truly, almost everyone who walks into your clinic who's a diabetic are not the same, be it a type 1 diabetes or type 2 diabetes. Even with the calcium score of 0 in type 2 diabetes, the warranty period of the power of 0 extends. And someone who is neither diabetes or metabolic syndrome with a higher calcium score is much higher risk than somebody with diabetes with a calcium score of 0. So the question is, we shouldn't always be patting ourselves on the back for treating every diabetics and potentially much aggressively than somebody who's non-diabetic, because the risk may be disparate. And same thing with severely elevated LDL, although the US and I would say the global guidelines wouldn't even want you to do any risk stratification. Clearly, as you can see in this paper from MESA, that almost 35% of individuals have no atherosclerosis, I would say the prognosis is well preserved over the period of 10 to 13 years, where majority of the events, almost about 2% per year CVD equivalent, happens with the calcium greater than 100. So this is really where we need to focus, where the power of zero will allow us to pay more attention to those who need versus where we can have some more flexible goals. Of course, one of the issues is most of the data so far is in the middle age and adults, but emerging evidence from US is suggesting that targeted approach, especially those with family history and premature family history of premature cardiovascular disease, metabolic syndrome, which is highly prevalent in the South Asians, may help us hone down where you can identify with the calcium testing a 1/3 or 1/4 who would have earliest atherosclerosis if the goal is to prevent the progression of the disease and subsequent complications. So in my view, age is just a number. We are ready to lower the bar for coronary artery calcium testing. I would definitely caution with this risk enhancing concept, because most of the recent studies have now, at least from our group and led by Jaideep Patel and Mahmood Al-Rafai, suggested that, like any other risk factors, as you can look in this group, that individuals with 10-year risk of 7.5%, almost 35-40% will have a calcium score of 0. You can have elevated lipoprotein A, but your risk is below the threshold for statin treatment. And you can even have 3 or more risk enhancing factors. For example, a patient can walk into your clinic with 10-year risk of 10% and have an elevated Lp(a), metabolic syndrome, and family history. There is a 40% chance that they will have a calcium score of 0. And you can see, by the way, their risk is much less. Whereas you may have no risk enhancing factor and have a calcium greater than 100, that's seen in about 25 to 30% of population, your risk is almost 2.5, 3-fold. So let's not miss the right individuals with just focusing on risk enhancing factor. And I believe the time is that we should be starting with the calcium testing first. Also, clearly, while I appreciate the guidelines classifying South Asians as risk equivalent, but clearly you can see, even if they're a statin candidate, all you have to do is look at your left, your right, and yourself. One will have no plaque, one will mild, and one was severe. And I'm kind of wary that truly, are we going to treat all these individuals the same? If we believe that they are not the same, so let's not treat them the same, because with calcium score of 0, you can have much flexible goals. Definitely early atherosclerosis, initiation of statins, whereas those with the calcium greater than 100, I truly believe that it's time that we start treating them as CVD equivalent. So in short, over the last 32 years, calcium testing has come a long way, with thankfully the 2018-19 guidelines giving a boost to the coronary artery calcium scoring. Many believe that we need to talk about the calcium testing before starting a statin. I think this test can not only get millions of people who don't need statins, but help us allocate the resources who do need it. It's guidelines indoors, ready for prime time, even in South Asian. So my question, where I want to end this, and hopefully we'll have more discussion, is not why, but why not? Because it's a most precise measure for risk of clinical CVD event. We cannot treat too many individuals with limited resources. It's relatively inexpensive, at least in Pakistan, where the cost of statins is almost 2.5 to 3-fold higher than just doing a calcium score. It takes almost 2 to 3 minutes to do, and even my 13-year-old daughter can interpret it. The radiation is equivalent to a mammogram. But I'm thinking out, what is the advantage to the stakeholders, really, from the health systems, appropriate allocation of resources to a group likely to receive net benefit. From a clinician perspective, rather than having a gunshot approach, you can truly have a personalized assessment of risk on case-by-case situation. And a patient, most importantly, in South Asian, most who are extremely wary of committing to long-term therapy, especially statins, the question really is, do I need it? So with this, of course, the next talk will speak a lot about what is the future on this. Of course, we have spoken about the calcium testing, but there is tremendous potential with the CTA to assess the biology of the plaque. And as Suhail and others have stated, we still have to understand the biological, social, and environmental determinants of early atherosclerotic disease. I don't think so the calcium testing would be the right test. In these circumstances, CTA will be fantastic, and Bashir will definitely shed some more light. So to finish out here, I think even in the South Asian population, and that's our protocols for risk assessment and management decision, we can do better. Whereas it's time to change, moving from the biomarker approach and treating everyone with an elevated LDL or diabetes, maybe finding out the right patients who need the right treatment at the right time. So I look forward to your comments and thoughts after the final talk. Thank you so much.
Thank you, Forum. It was a great talk. And there's one thing that I hear people say sometimes on like Twitter that yeah, I saw one patient a year ago whose calcium score was 0, but that patient had MI. But what we should look at the bigger picture, right? Especially in the countries like Pakistan, India, Bangladesh, and because of the low socioeconomic status, I think calcium scoring has a great role to play in terms of cardiovascular disease prevention. So this will lead to the last talk of the day. It is on prevention versus intervention, a dilemma for Pakistan future strategies. And the speaker is a very good friend, Dr. Bashir Hanif, who returned to Pakistan about 15 to 20 years ago. And he's been instrumental. He's been one of the trailblazers in cardiology in Pakistan. So without further ado, Bashir.
Thank you very much, Well. It's a pleasure to be here with, especially among the giants in prevention and cardiology. I think most of the things has been talked about, because a lot of obviously problems as well as the solutions we share with, I would say, India or Bangladesh. And a lot of things has been covered about that. So I will try to skip those things and focus on few things which hasn't been particularly related to Pakistan. So I think I'm not going to talk about overall CVD burden. So briefly talk about current status of preventive versus interventional programs in Pakistan, challenges we are facing in terms of prevention of cardiovascular disease, what are the barriers to implement those any kind of preventive services, and what is the way forward or future prevention. I would like to thank Dr. Howard also. I did borrow a few slides from him. Again, I think we know it's number one killer, but one of the actually alarming fact for me, this is from British Heart Foundation, that someone has a heart attack every 2 minutes, which is really alarming for all of us. We know that the leading cause in South Asia, as well as dialysis and death from cardiovascular disease, is number one. In terms of, if you look at South Asian countries and if you look at Pakistan, basically 2/3 of the deaths as well as dialysis in South Asia, Pakistan shares more or less similar as compared to other South Asian countries. It's just probably a little bit lower than Sri Lanka and Maldives, but rest of them more or less the same, Bangladesh as well as India. Institute of Health Metrics and Evaluation actually has predicted that by 2030, cardiovascular disease will account for a higher proportion of deaths in low and middle income countries than in the high income countries. And if you look at South Asia, these are females and males, and the number is significantly high as compared to the rest of the world. Again, if we look at the health profiles of South Asian countries, and these are different, Afghanistan, Bangladesh, and others. And if you look at health financing, unfortunately, Pakistan remains almost, even in South Asian countries, at the lowest side. Overall total expenditure on health is 2.9%, which is lowest as compared to any other, even South Asian countries. General government expenditure is also on the lower side, and per capita total expenditure on health is also the lowest, and that is probably one of the major problems. Even in South Asian countries, Pakistan unfortunately goes down. And if we look at other factors among South Asian countries, this is the NCD capacity profile, and a lot of these things are, if you look again in Pakistan, it's basically, you see all of them are no. We don't have a risk factor survey, we don't have morbidity survey, service utilization. So a lot of these things which are required to really deal with these NCDs, unfortunately, are not there in Pakistan. We know there is a decline in the death rates from cardiovascular disease in Western countries significantly over last decade, while in South Asian countries, including Pakistan, these numbers are increasing, and this is the epidemiologic transition which Dr. Aisha mentioned as well. Now, we also have some data from Inter-Heart study on South Asia as well as in general. 9 simple risk factors were responsible for almost 90% of the risk of AMI. And if we talk about South Asian countries, we know that it comes at a much younger age, the acute MI. And if we focus on those risk factors, we may be able to prevent those acute MIs. We know in the past it was a dual burden of communicable and non-communicable diseases, while now with the epidemiologic transition, non-communicable diseases are surpassing. Almost 2/3 of the total disease burden in Pakistan is from NCDs. And again, the numbers may not be exact. There are some estimates in it. Around 12 people die of heart attack every hour. And I'll show you the recent the CROP data, which is the cardiac registry of Pakistan. The average age of first MI was around 55, 56 years, and there was 6 years younger with a higher number of risk factors in the younger population. And unfortunately, I think just like other South Asian countries, there is a poverty trap. Anyone who gets a heart disease, this is going to make things worse. People have to sell their houses, and then they keep getting worse and worse because it's a lifelong disease, and the overall health conditions continue to worsen, resulting in this trap. Ischemic heart disease remains number 1 cause of death. Life expectancy, looking at Dr. Aisha just mentioned earlier, it's actually even less than Bangladesh. According to these WHO numbers, it's like 65.7 years. Again, cardiovascular disease is number 1. And overall deaths around 20.28%, and Pakistan ranks in the world around 18th in terms of total number of deaths from coronary artery disease. No, this was the first paper. We actually had an abstract presented at American College of Cardiology from our cardiac registry of Pakistan, which I'll briefly tell you later on. We were actually lucky to have this, and this registry, as Dr. Smear mentioned as well, they are trying to do these registries in India as well. And this really helps a lot to find out overall disease burden and what can be done about it. And we were able to start this cardiac registry of Pakistan, and this was mandated by Supreme Court of Pakistan that every cath lab has to be part of it. And we looked at the risk profile and outcome of patients with premature and extremely premature coronary artery disease compared with older adults. Now, premature, we label less than 65 in females and less than 55 in males, and extremely premature, less than 40. And looking at that, we actually looked at almost 15,000 patients, and out of that, around 6,000 were older and 9,065 premature, and almost 1,118 extremely premature. And as Dr. Aisha mentioned earlier, our numbers for premature and extremely premature for females were actually around 30%, as compared to what she mentioned, they were lower. But surprisingly, in older age group, which is like more than 65 years old, the females were only around 10%. So I think, again, the reason which was discussed is more likely they won't present to the hospitals as compared to not having the disease. Disease is almost there. So what we were able to actually conclude in this, that frequency of traditional risk factors, especially tobacco smoking and obesity, were particularly high. And again, the risk factors in the premature and extremely premature were much higher as compared to the older adults. Sorry, 1 second. So I think there's a significant economic impact or burden. In 2005, it was estimated again around $1 billion of national income from premature deaths due to heart disease and stroke and diabetes. And this estimate is going to increase to $31 billion in next 10 years or so. We know that there is a mismatch or a 90-10 disequilibrium between established market economies and all others, that overall the expenditure is 90% on overall Delhi's and is like 10%, while in low income countries or middle income countries or developing countries, it's the other way around, that Delhi's are much higher, like 90%, and the health expenditure is much lower, as I showed in earlier slide also. There's a care gap also. It has been actually shown in a Pure study that low to middle income countries are really unable to, due to socioeconomic problems, unable to really take these drugs which are necessary for secondary prevention. And even if you look at overall and high income countries, the number of drugs were much higher as compared to in the low to middle income countries. So Pakistan socioeconomic, I think this problem is true, same for India as well as Bangladesh. We do see from one extreme to other extreme. These are present in Pakistan and other low to middle income countries also. And similarly, there's a health polarization also. Those who are able to afford, they can go to these private institutions, while others has to go to these government institutions where facilities and services are not that great. I think all of you have heard about this thing that someone was trying to save someone who was being drowning in the stream, and without realizing that who is pushing that person down into the stream, and he kept trying to save them. I think if you keep trying to save it without realizing the cause, it's going to be very, very difficult. So I think our most of the time response is anyone we see, we start applying CPR without realizing we need to establish the cause and find out what's going on. We start working on mostly like creating new state-of-the-art tertiary cardiac care centers. Even in Pakistan, every city, there are new hospitals and tertiary cardiac care or even tertiary general centers are being made, but no significant preventive cardiology service or setup is there. Again, top-line procedures, everyone is really very proud to tell that we are doing the best procedures or most difficult procedures without looking into the cost and benefit. Primary PCI definitely has a role, and as Suhail mentioned, they are doing a lot at Cardiovascular Institute in Pakistan in Karachi. But again, I think it is very important to keep an eye and look at status of secondary prevention and primary prevention. Now, if I give you some numbers, prevention versus intervention in Pakistan, currently there are around 130 to 135 cath labs all over Pakistan. And the registered or certified interventional cardiologists is around 475 to 500. Versus preventive cardiology programs or institutes or departments are in the institutions is maybe only 3 to 4. Dr. Howard Kazmi may have one, we have one, and maybe 1 or 2 other institutes have those preventive cardiology setups, but those are also in a very primitive stage and not really up to the mark. And if we ask, are there any preventive cardiologists? And the answer is going to be really none. We can see even in this symposium, most of us are sitting there are mostly interventional cardiologists as well. There are a lot of reasons behind it. Obviously, financial is one. There are no proper training programs for preventive cardiology and no real incentives. I can tell you in our program, we recently advertised for an interventional cardiology fellowship. For one position, there were almost like 50 candidates. And I've been trying to have a preventive cardiologist in my program for last like 2-3 years. No one is willing to become a preventive cardiologist. This is unfortunate, but that's the reality of the fact. Health structure and system in Pakistan, mostly it's private sector. 70% of the patients get their services from the private setup, and that is fee for service. Healthcare services by, again, armed forces, hospitals, NGOs, and social security institutions, they facilitate their own providers. There is no real mechanism to monitor their clinical practice or quality of services. And obviously, there is a non-existent focus on preventive healthcare services. Unfortunately, that is true among all across the institutions in Pakistan, and I think probably true in other countries, these developing countries as well. There are poor health indicators. We all know very well. We all talk about it. We know, all of us, that prevention is the key. There are different ways to prevent. We talk about it, but unfortunately, the focus of the government as well as the institutions and society is not as much as it should be. We know that risk factors starts in the childhood. We focus on maybe adults, but we forget the childhood and youth. Worldwide, there are 22 million children under 5 years who are obese or overweight, and they are at a significantly high risk. Again, similarly, the smoking is becoming very prevalent in young children or youth, and that is again a major problem. Hypertension, type 2 diabetes mellitus, these are also becoming high. This is one of the studies, I think Dr. Howard was part of it, Habit, in which they looked at the school children and found there were significant children, number of children who had increased waist or BMI was significantly on the higher side. Government, again, autonomous and private health institutions has to play their role, but unfortunately there are lack of resources, misdirected priorities, lack of political will, and that's one of the major problems. In terms of the risk factors, one of the recent studies did show that around 40% of the Pakistanis were hypertensive, another 20% were using tobacco, another 20% are high cholesterol, and around 20% of the population was obese, and around 11% pre-diabetes and 17% diabetics, which is very high number. And similar are the numbers with dyslipidemia as well. There is significant potential for prevention just by controlling risk factors. We saw in inter-heart study also 90% of the acute MIs can be prevented if we look at all these modifiable risk factors which are present. We know this is really becoming alarming. Tobacco control legislations are available all over the world. We can learn from them. We can have it. Unfortunately, it's not happening. In Pakistan, I just found out that the lowest tax in the world on cigarette is in Pakistan. So it's so easy and so cheaper to buy as compared to other countries. So really need to work on that. Overweight and obesity, even it used to be considered the disease of the developed countries, but now it is in the developing countries also. Physical activity, unfortunately, is lacking in schools or even later on, especially in urban areas. It's becoming very, very difficult. No guidelines. Again, we have seen, this is one of the pictures from one of the cardiology meetings, and you can see no one is going on the stairs and everyone is, and this is true with us also, we do the same thing, and unfortunately that's causing a problem. Dietary guidelines are lacking. Again, we really need to focus. There are several, we know there are examples of community-wide cardiovascular prevention programs that has a significant impact, and we can learn from them and try to implement in our country. There are several constraints for having these prevention programs, but again, there is a will, there is a will, there is a way. We can find out the ways to really put those into place. Limited recognition and available data on CVD. There's no commitment, unfortunately. Prevention is not taken seriously because of the market pressures which are favoring the interventions. Again, healthcare needs not addressed. Costs are rising and resources are really decreasing day by day. Everyone has to play their role, but unfortunately, government, there is very bureaucratic, slow and ineffective, failure to influence. And I think I'm sure all these words must be familiar to my other friends from India, Bangladesh, or other developing countries. The same problems are in those countries as well. Medical education systems, again, is not geared towards prevention. That is also geared towards therapy and treatment. And we need to really focus on that. And we need to incorporate this prevention in our education curriculum, whether it is undergraduate or postgraduate. We need to have public health institutions where we can train these people, and those healthcare systems, preventive systems, can really help to improve all those things. There are significant barriers. We can overcome those barriers. And I think one of the things which I wanted to talk, and Khurram also mentioned, I think first time in Pakistan, we are launching with this study by the name of Pak Sehat. This is going to be all across Pakistan in younger people, less than young, like 35 to 45 males and 45 to 55 females. We will have at baseline, basically all their evaluations and anthropometric measurements, as well as history, physical, and all their risk factor profile. And then we will have actually baseline labs. In addition to that, I think two other things which we are going to do, which Dr. Khurram also mentioned. One is that we are not only going to do a calcium score, but we'll be doing a CT angio on these patients to really characterize the plaque. And on top of that, we are also going to have a carotid ultrasound to look at intima media thickness. And the primary objective is to characterize the prevalence and severity of subclinical coronary atherosclerosis among young Pakistani men and women free of clinically symptomatic ASCVD. And also, as we have discussed again and again, that the risk factors or the risk scores which we use may not be applicable to South Asians. And this study will also help us to really calculate the risk scores. And we are going to follow these patients over 5 to 10 years and look at other secondary endpoints as well. This will be a landmark study and hopefully will help us to look at a lot of things and hopefully answer a lot of questions and help in terms of decreasing the burden of the disease. Again, I'm not going to go into the details, but again, there are several preventive strategies, primary, secondary. One of the most other important thing is, unfortunately, I think it's probably more problem related to Pakistan, is that strengthening of research capacity that is very lacking in Pakistan. Basic knowledge of epidemiology, biostats, and public health should be core components of postgraduate education, and CME training programs should be a must for doctors. And that will help us to build the capacity for research, and that will help us to actually improve the surveillance system and have a data to base our planning on that. And that's why we are now having these, as I mentioned, cardiac registry of Pakistan, CAT PCI. We are also launching a heart failure registry and EP and device registry. So these registries and the research for the primary prevention will help us to improve on things. There are more than 50 medical universities and colleges. Only few institutes have accredited public health research training programs, no school of public health, and minimal training. Few medical journals are indexed. So publications are also limited in international journals. So we are lacking behind, and we really need to work on those things. I think I just a couple of more slides, and already time is over. I won't go into that much detail, but key components of CVD prevention according to NICE guidelines is we need to tax on tobacco products and ban on public smoking. Again, there are a lot of active groups who are working on it in Pakistan, but unfortunately things hasn't happened. And as I said, this is the lowest tax currently, and we need to get together and try to convince our government to look into that. Reduction of salt, saturated and trans fats, and food labeling is very important, which is not there. We need to change our agricultural policy, physical activity, health monitoring, and all these things really actually for the future of CVD in Pakistan. We need vision, commitment, and dedication from cardiovascular community and leaders and professional societies who really can do it if we work together. And as these 4 A's, I think Dr. Smearwich mentioned, we are probably at the same crossroads. We have access and we have affordability, but again, the quality and monitoring and all those things are not there. I think the few things which has really happened well and is going to go a long way for Pakistan for in terms of access and affordability. Pakistan government has launched what we call as a Sehat card, with which every person can go to any hospital they want and they can get a procedure. Obviously, there is certain limitation, but this has really revolutionized the treatment and therapy. But unfortunately, again, the prevention is not covered under this card. Similarly, cardiac registry of Pakistan, that is mandated by Supreme Court for every cath lab. This will help us to have the data and basically plan for the Pakistan in terms of overall cardiovascular disease. Recently, Khan has received significant research grants for training the personnel and the resources in research. That will also help us to improve in terms of conducting research. And Pak Sehat study, which I just mentioned, has really helped a lot. I think I won't be going into those details. Just last slide. Here again, as I mentioned, every one of us has to play a role, the government, cardiology institutes and universities, private sector, and we need to focus all of us on NCD prevention. Problems are there, hindrances and challenges are there, lack of awareness, lack of resources, lack of political will. But as I said, if we really work together and all these get together, we can make a difference and will be able to do something. And we need to have full-time public health experts, our cardiologists, education and training of all these family physicians, faculty and fellows, and children and youth and public, and everyone need to be trained and educated about primary prevention. And the way forward is really there. Eliminating major risk factors for non-communicable diseases can prevent almost 80% of the heart disease, stroke, and type 2 diabetes. Enemy is there in front of us. We do not need drone attacks. We need to take it on up front. So Sehat card is an excellent initiative, and unfortunately, as I said, no preventive package. We know a lot what needs to be done, but unfortunately, we just does not get it done. And but as I said earlier too, we can definitely change it by working together and working in collaboration, I think we can achieve. Where there's a will, there's a way, and we can definitely do that. With that, I would end. Thank you very much. I'm sorry if I took a little longer time.
Yeah, thank you so much, Bashir. It was a great talk. So we have gone over time, 90 minutes. So what I'm going to do, I'm going to give another 20 minutes for Q&A and discussion. And I'm going to open the forum for discussion. I'll be joined by all the panelists, plus Dr. Khawar Kazmi, who's the head of preventive cardiology at NICVD, as well as Viet Lee, who's a very good friend from Salt Lake City, who's always passionate about preventive cardiology.
Well, maybe I can take a lead here.
Sure. Yeah.
Okay. Well, when I look at you, I mean, it's kind of I have mentioned already, it's kind of a deja vu. When I came back in early 90s after my intervention cardiology training and started doing PCIs, I exactly had the same feeling as you had mentioned, and our colleagues from Bangladesh and India. And that's what changed my heart. So, and I think maybe I can make a correction to Bashir's rendition that maybe I am one of the preventive cardiologists who is dedicated to prevention, because I stopped doing intervention and focused my whole thing on prevention. That was the time, I mean, mid 90s, that Salim Yusuf approached us at AKU and we joined Interheart, and so India was part of that. Srinath Reddy and Prem Pais, and from Bangladesh also. Actually, Aisha, I mean, when the Diabetic Association was starting the cardiology hospital, the two cardiologists who initially started intervention there had a brief exposure at AKU with us to start the intervention there. So, I mean, so what was mentioned in that, I mean, my worry here is that in 30 years, I've been talking about exactly the same thing as we are talking today. The numbers have become worse. The actions have not changed. Interheart, Salim mentioned Interheart, and Salim, he also mentioned the positive side of the positive message of Interheart from Interheart South Asia. Yes, it is a positive message, but it will only be positive if we would do something about it. We have not done anything about it. We're still talking about the same thing. We need to do more research. We need to know more about this disease in South Asians. But I think we need to also act on what we already know. We know about the lifestyle. We know from Interheart about the lack of use of fruits and vegetables, the physical activity, which is so disparately low in South Asian countries, both India, Bangladesh, Pakistan, all of us. We are all on the same boat. But unfortunately, I think we all, I mean, as Bashir has mentioned about the things which we are doing CPR at the time. So this is my worry, and I really would want to see that we are not doing the same thing 20 years later. We do something which makes a difference here. If we don't make a difference, the boat is going to sink. I think so. That's one of the important messages which I'm going to say. Khurram, I think from your talk,
just one comment. I just wanted, I think so you've raised a great point, and it makes me wondering, you know, if we are producing crops that or food that nobody is eating, shouldn't we be now trying to grow different crops? I think so. That's really what it is. It seems like this whole redundant approach in preventive cardiology, as you know, it's a newer field. Even in US, it really came into being in the 90s, which really grew from lipidologists. Really, that's what the preventive cardiology was. And I think so, you know, it just seems that the public's not attuned to this whole concept of treat everyone. And you're rightly bemoaning that it hasn't gone traction because there is no model. But I think so that's what we need to work in. Do we need to create the Amtrak or do we need to jump to the bullet train? Because that's kind of the whole thing is, if you look at in China, they're doing the bullet trains, nobody's making the Amtrak. So I think South Asia has an opportunity to leapfrog and learn from the mistakes of the preventive cardiology programs over the last 20 years in US and do not make the same mistakes. So I think so that's kind of what we need to do is think what is going to be applicable.
Yeah, I agree. I think I agree. But I think we need to have more innovative approach making this in a limelight. But I think just one point, I was going to take from your, I understand the need for, the role of calcium score. And you mentioned, it's cheap in Pakistan, 3,000 rupees. 3,000 rupees is about 10% of the average monthly income of about 40% of Pakistan's population. And so if they get a CT calcium score done in 3,000 rupees, they may have to starve a couple of their children in house for a couple of days. So although, I think it's cheap from US standard, but I think we'll have to really look at that from that point of view. And I think your point again, I think we need to have more attractive approach, which can change people's approach. And similarly, I think which is more kind of implementable at a larger scale in countries like Pakistan.
Agree.
So,
I think,
I agree. I just want to add on this because this was a question directed here. So let me chime in first. So you're absolutely right. 3,000 rupees is pretty high, but the statin cost is almost 7,500. So the same pair as an health economist, I'm just thinking out loud that as a health economist, if let's say it's the Sindh government in your case, or maybe the Punjab government, or even the family or any foundation who's willing to pay 70,000 rupees of medication for 10 years, I think so it may be worthwhile scanning 3 people for 10,000 rupees to identify one who may not need it. Now, again, we have to figure it out. But the other issue is I've spoken with family members, friends, even colleagues and other, and say, are you really asking me to go on a statin for the next 10 years and 15 years? Why do I need it? So, we are facing with diversing realities, and we are coming back with the same solutions, trying to convince more people that I can't even convince in US. And we are having bigger trouble in the South Asian. And that's what I think is the definition of insanity, is trying the same old things and asking for different results. So we need to be more creative. I'm not saying that we should be just doing calcium, but these are kind of the innovative approaches which will help us for resource allocation. And the government of Pakistan and the provincial governments need to play a big role there.
So I agree. I think even for statin point of view, Bashir, I think showed a slide from Pure. And so Pure again, I think is India is part of Pure, Pakistan is too, so is Bangladesh. So in Pure study, again, Salim Yusuf leading that, almost the use of 4 secondary prevention strategies, which are aspirin and a beta blocker and a similar and statin, the use is less than 1%. It is in those people who already had an MI or stroke. So, statin is also, not something, we're talking about primary prevention. Here, not is being used in secondary prevention. So we need to have a very different approach, and government is not into prevention at this time. As Bashir had said, we have a Sehat card, which covers a cost of ₹1 million for a year for a family, but it does not, it would cover the cost of stroke or a PCI. It would not cover the cost of use of hypertension medication. So, they will not prevent a stroke, but they will treat a stroke.
Yeah, I think, Dr. Kazmi, I think we are too stuck on just the statin therapy. I think, look, there are some things that the countries like US and UK have done well that we can learn from as well. And I think what they decided in 80s was that we're going to have 2 sides of approach, right? One is the high risk strategy, and one is the community level, the population based strategy. I think what Aisha presented, what Samir presented, what Dr. Bashir presented, I think that high risk strategy has to stay. Those highest of the high risk need to be taken care of, need to be on guideline directed medical therapy. And that's what has led to 50% reduction in mortality in US. The other 50% is related to better risk factor control, which again, we've had a slight increase in obesity and diabetes again. But in the last 50 years, that's where I think a lot of work has been. And I do believe what Dr. Bashir was saying. I think we do have an opportunity to go back to some of these schools and do some. I think if you look at the South Asian countries, social media is even more powerful than some of the other regions, actually. So leveraging that, how do we get people to even have these minute differences whereby even 2 millimeters of mercury blood pressure reduction at that level can lead to very large reductions 20 years down the line? I think it's not just about statin therapy. Yes, that we can talk about, but I do believe that there is a lot of work that needs to go in these other risk factor control as well. And even in young people, we don't even know what's the FH prevalence in Pakistan. I mean, that's like an easily treatable disease. There's not too many questions that are being asked. So I think we need to look at both of those. And what I worry is that we try to study the disease a lot. So we get into this analysis paralysis mode. And then we just study blood tests, lipid tests, imaging studies. I think we need to have a parallel arm where actually there are people who are just dedicating their life to interventions and learning from that as to how they are scalable and what is the best strategy for various parts of South Asia. So I think both of those need to happen in tandem.
So just trying to piggyback on what you said, doing something on a population level, and also what Bashir said in his talk, that there need to be more collaboration among the institutes in Pakistan. So there's one thing that I talked to you a couple of days ago, and I talked to Power Kazmi before the webinar. We are in the process of designing a study where we are actually looking at lipoprotein A levels in South Asia. And again, most of the study, when we did the literature search, was done in UK. South Asia is living in UK and USA. But there's something that, again, we are seeing more prevalence of that disease here in Pakistan and India. So we need some more local data on it, even in those patients who have normal LDL. So that could explain why we have such a high disease pattern. So I've also talked to Dr. Aisha Kader about this study, that we can do an arm over there, and Samir Gupta as well. And we will definitely talk to Dr. Bashir Anif as well if you want to come on board. I mean, that will add so much to the question of lipoprotein A. And I'm getting so many questions here on the chat box. We should definitely do another webinar just on lipoprotein A sometime.
Yeah, can I quickly say something as well? We have included actually lipoprotein A in our Pak study, and those 2,000 patients from all over Pakistan. Actually, we are going to collect the data on 4,000 patients, but CTA will be done on 2,000 patients. So we will have LP(a) on 4,000 patients all across Pakistan as well. So that will help us to do that. My question to Salim was, ApoB, which you are mentioning, we were actually discussing, and we will have the steering committee meeting and discuss that. Do you think that should be considered also? I don't even know if it is done in Pakistan or not.
ApoB is available. It's even more easier, easy test to get done than lipoprotein (a). So I am almost certain it can be done. And ApoB assays, again, there's a little bit more standardization that's needed, but it's there and it can be done. And I do believe that in Pakistani or Indian or Bangladeshi context, South Asian context, you will find that that is an issue, that discordance that people talk about, and then for very good reasons, because of high triglycerides and insulin resistance. So it can be done.
Thanks.
Just clarification there. I think ApoB was the one which was used in InterHeart. ApoB is not available in Pakistan at this time. But I think we talked about it earlier, Salim, I think when you were visiting, non-HDL cholesterol, I think that is a very good cheap alternative of ApoB, and I think that's what we should be focusing on and try to, put that more in practice rather than the LDL as we're doing now.
Yeah, no, I agree with you. My PhD was on non-HDL cholesterol. I think one of the comments that we had, I made that comment that non-HDL cholesterol has more than 90% correlation with ApoB. And I think there is a debate that when non-HDL cholesterol and ApoB have discordance, which is actually a very small proportion of the population, whether risk tracks better with ApoB or non-HDL cholesterol, that's a debate that I don't think we should get into today. But generally speaking, non-HDL cholesterol is what we call poor man's ApoB. And that really is what we should be using now in in Southeast Asia and perhaps everywhere. It has been part of the guidelines here in US as well for a very, very long time. So.
Samir, you have a question?
I just wanted to say a comment. I'm hearing all of you speak, and it's kind of echoing very well with me, because I think the practice patterns that we have in Pakistan and Bangladesh are very similar to what we have in India, where majority of the healthcare is provided by the private sector, and the government sector does play a role, but a comparatively a smaller role. One thing is the mentality also, which I find very different between Southeast Asia, or I would say India, and compared to my time in the US. In the US, there was this concept of work-life balance, right? I mean, people would say, it's 5 o'clock, I'm going home, I'm going to go work out. It's a weekend, I want to go hiking, I want to drive my bicycle. That concept is very nascent in India. Even when you go for a walk and you see people, say, my patients, I ask them, do you exercise? Do you walk? And the answer is yes. I go every morning and I do my yoga and I do my morning walk. And then you ask them, do you sweat when you walk? And 90% of the times the answer is no, I don't sweat. So, the question is, are they actually taking their heart rate to the target rate where they get cardiovascular benefit, or they're just walking for the sake of walking? I mean, what is the physical activity that they're doing? Is it actually effective physical activity? That's just one thing which has always been bothering me. And also to the next point of, we're talking about LP cholesterol, a lot of cholesterol and lipidology. What about polygenic risk score? I know that that's not really panned out. What is the role of genetics? I know that multiple companies have been sprouting up in and around India, where they're doing genetic testings, and 23 and more is big in the US, and there are similar companies in India where you get I got a blood test done also. I said, let me see what my risk score is, and this entire thing came out, and I had no idea what it meant. And the counselor who was there on the other side was also equally ignorant. So I didn't really put too much effort into trying to educate myself. But these polygenic risk scores, what is the role of that in your opinion? Can we study that a little bit? Just wanted your thoughts.
I can take that polygenic risk score. So, I mean, there is association. I think the question is, you take polygenic risk scores, you take traditional risk factors, all of that then comes to subclinical athero, and I think that's what Khurram would probably argue. We have something that should be coming out looking at what is the utility of polygenic risk score in somebody with zero calcium. I mean, the answer is generally pretty low. I think the only area where there is utility that we should not throw the baby with the bathwater is that polygenic risk score can be assessed very early on in life, right? Subclinical athero takes time to develop. So if you have very high risk families, you could use polygenic risk score early on to work on lifestyle and perhaps treatments as well. So I think that's where utility is. But I do believe that once you turn 30 and 40, then markers of subclinical athero generally are a risk multiplier that gives you an idea of a summation of every kind of risk you may have. But early on in life, I do believe that in those who are 10, 15, 20, 25-year-olds, I think there is perhaps some utility for polygenic risk scores, especially in the South Asian context.
So I agree with Salim. I think so. Genetics is your first risk factor. So that's fantastic. No other risk factor you can do at age 10 or 15, and you can truly make significant lifestyle intervention, which has shown to curb the future trajectory. Once you get above 35, 40, of course, if the decision is what's your true risk, genetics is like any other risk factors. It will track, but there is going to be disparities. So to guide management, subclinical athero may be a better one, but I'm a big fan of polygenic risk score. I think so early on interventions in their teens and 20s is the right time to get it.
And the other issue we have is that the polygenic risk scores right now are very much geared towards Caucasian populations. We really don't have any polygenic risk scores in South Asian. So we're hopeful that with these large data sets we'll have a little bit more information on that as well.
Yeah. I mean, that's one thing that we've been talking about in our hospital registry, that, should we take, when you're doing 2,500, 3,000 PCIs, plus sending so many patients to bypass, how about we just do, 100 patients of these or 200 patients of these and see which of the markers came up. There is a PhD who's wanting to tie up with this. This is something that we've been debating with But the practice patterns are also very different, because here we are talking about affordability, that that 3,000 rupees is very expensive for someone to get a CT angio. And on the flip side, Dr. Kazmi, there are this whole group of people who are kind of affordable people, and they come to you and they say, Doc, I just do every test under the sun. My friend had a heart attack. We all have those patients, those family members. Somebody in my network, he was 27 and he dropped dead. Just do every test under the sun, and you're left scratching your head. Should I do a CT angio? And then they come 2 years later again. My CT angio showed 25% blockage last time. Do I need to repeat it? It's a complete treatment dilemma, breaking every guideline there is.
All right, guys, just for the sake of time, we'll take the last comment from Asha Kadir. If there is a burning question, Dr. Azmi, you can also ask. Again, we are over 2 hours now.
Yeah, I was just going to say, I think the key here is obviously what Salim had said. There's a difference between population-based approach and individualized approach, and that's what has to be done. But I wanted to put a question to Salim. There was a paper from Pure, again from Salim, I think, talking about urban arm and the rural arm. And in the rural arm, there was higher risk with intake of refined carbohydrate rather than fat intake in the diet. What is your take on that?
Look, I know we have a lot of debate around Pure as well, how reliable the food diaries that were used were. I think one thing is for sure that refined carbohydrates, very high quantities, are not good one way or the other. That may be the best fuel source we have because it's cheap. But I think we have to take it with the totality of the data. And the totality of data is that, when you have very high levels of especially saturated fats, that's not a good thing either. So as much as we can move from saturated fat to polyunsaturated fats and keep carbohydrates under check and balances, that we're not going above 50-55% of the total calorie intake, it's probably a balanced approach. I think balance is the key here, not going one way or the other, because then cost becomes a major issue as well, especially for the kinds of patients we're talking about today.
All right, last comment or question from Asha, and we will
Thank
conclude.
you.
Okay?
Thank you for putting this together, Sohail, and setting the momentum, really, because I think as we've discussed, the incentive for prevention is so little in South Asia, because as Samir said, I echo that sentiment that the vast majority of the practice is private practice based. And even among us, where in Bangladesh, there isn't a separate IC fellowship, so to speak, unless you pursue it. So the vast majority of us don't go into imaging, irrespective of what it is, we just go into intervention because that's where all the incentives lie. So I think it's really time to side by side, along with research, incentivize the prevention aspect of it, because we're seeing so much more of young MIs and so much more of lethal mortality inducing MIs that we should focus a lot more on prevention, even if we're interventional cardiologists. And that's just really the take-home message that I took, and I learned a great deal from all the talks today as well. So thank you.
All right, with that, we will conclude today. Thank you so much for all the panelists and the attendees. This is something we should do more often, and we will definitely come back in a couple of weeks. This will be recorded. It will be shared. So again, thank you so much for all the panelists for your time, and hope to see you again. Thank you.
Well, we are just one last thing. We are planning another primary, the preventive symposium with Khurram and Salim. I think either July or September. So we'll work together and have all these people, and probably that. I think we should be doing it more frequently. It was great. Thank you.
It's a good segue. Thank you, Sohail, for leading this. This has been fantastic. As you can see,
So Bashir, I gave ideas. We should
high.
do active cardiology. Yes, it is. And then Bashir, I gave idea that if we want to start like a preventive conference, we should do 1 year in Pakistan, 1 year in India, the other year in Bangladesh, and that's something we can rotate.
The only problem is the visa issues with India. It's become.
But
so
Samir will figure something out for us. Right? Yes, Samir.
We'll figure that something out. I'm sure Samir is here, so he'll help.
Samir, no pressure.
All right, guys. No
Okay,
pressure,
thank you.
Sunil.
Thank you,
Thank you.
Sohail, for leading that.
Thank you so
Bye.
much.
And thank you.
Thanks,
Thanks,
Sohail.
Sohail.
Thank you. Bye.
Thank you.